Welcome to Same Surgeon, Different Light. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast. My name is Sherry Erkman, and together with Sara Pereira, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We'll learn about backstories, career challenges, and what makes each cardiothoracic surgeon unique and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons. I'm Dr. Sara Pereira, and today I'm so honored to be joined by Dr. AJ Carpenter, Professor of Surgery at University of Texas in San Antonio. Dr. Carpenter has built an extraordinary career, blending her impressive academic achievements with a distinguished military background, as well as a trailblazing approach to surgical techniques in cardiac surgery. During today's podcast, we will learn more about her unique career path, her secrets to success in cardiac surgery, and her personal hobbies and motivations that have guided her career. We are really fortunate today to have Dr. AJ Carpenter with us. Dr. Carpenter, you have always been a huge role model for me personally in both education and navigating cardiac surgery as a woman. And I've always wanted to ask you all of your secrets for success as a highly successful woman in cardiac surgery and practicing in San Antonio, Texas in the South. What I've admired most about you at our national meetings has been your kindness and really calm demeanor on panels and committees, and your advocacy for students, residents, and early career surgeons. So Dr. Carpenter, welcome to Same Surgeon, Different Light.
Thank you. Glad to be here.
I would love to hear your advice on career success and our surgical culture in cardiac surgery. But I wanted to ask you first about your career inspirations, as your background has been really unique. As you know, Nina Starr-Braunwald was the first woman certified in cardiothoracic surgery in 1961, and you were the 87th woman certified in the American Board of Thoracic Surgery in 1998. And now, 37 years later, there are greater than 4,500 men certified in the American Board of Thoracic Surgery. So you were certified in the same year as Doctors Margarita Camacho, Jane Schwab, and Patricia Thistlethwaite, all female pioneers in our specialty. So with your background, what inspired you to go into cardiac surgery?
Well, that's kind of a long story. I grew up in North Carolina, so in the South, at a time when girls were kind of told pretty much whatever that was, you couldn't do it because you were a girl. It was you can grow up to be a nurse or a mommy or maybe a teacher, but that's about it. And I had a sense that there had to be other things in life, and those weren't the things that appealed to me. So I had kind of a long search for what that was, and hence, I ended up being a ski bum and getting a master's in physical education and then a PhD and working as a scientist for a while, and ultimately went to medical school. And when we were scheduling our third year rotations, I had this notion of being kind of like Dr. West, who wrote the book about mountaineering and respiratory diseases, and thought, I'll go into medicine and be a cardiologist or a pulmonologist and do research in the mountains, and that'll be cool. And then I did my rotation on surgery, and I actually had a cardiac surgery rotation because nobody else wanted it. And so I kind of got it by default and found myself standing at the table the first day on that rotation across from Al Pfister, who was a fellow at the time, and saw the beating heart and discovered, ooh, this is what I'm supposed to do. And never looked back after that.
That's amazing. I remember my very first time in the operating room looking at the heart, thinking exactly the same thing. And so I think that all of us in this specialty have that aha moment where you just absolutely love cardiac surgery. And many years later, how was your feeling when you walked in the cardiac OR?
I never stopped being amazed. This is a wonderful career. It will consume as much of you as you will let it consume. But if if it really fits you, there's just nothing else that's going to be satisfying.
Yeah, absolutely. So you alluded to your past background being a ski bum and a scientist before medical school. When you applied to medical school, what did you think you wanted to be or go into?
I really kind of thought that going to medical school was something that would just strengthen my credentials as a scientist who did research on human factors, particularly exercise and environmental physiology. And so I really came to the clinical years with a pretty open mind. Um, Although, I sort of thought along the lines, like I said, about being in a medicine specialty where I could do research and outdoors in the mountains and things like that. But um, I approached every rotation as, let's see what this is like, which is a piece of advice I always give to students well, whether they ask or not. Uh, Keep an open mind and see what feels right to you. You might be surprised, because I certainly was.
Yeah, absolutely. So before medical school, and after medical school, you achieved the ranks of a lieutenant colonel in the Air Force. You've been chief of cardiothoracic surgery at Lackland Air Force Base and professor of surgery in San Antonio. So your achievements in all of these true male-oriented careers have been really impressive. One of your friends in San Antonio told me about your master's in physical education and PhD. And so, with all of these successes and your love for the mountains, have you ever doubted your decision to be a cardiac surgeon?
No, well, actually, that's not true. Sure, there are times when you do doubt whether you made the right decision. And but the overwhelming joy you get out of the time you spend taking care of patients and seeing people get better is so much more than the moments that you regret, if I think honestly about moments that I regret, I can think of patients that I lost that I maybe shouldn't have lost, or at least thought I shouldn't have lost, or patients that really struggled and had a hard time, and I developed these very sad but challenging relationships with their families. Um, But on the whole, no, I loved being a heart surgeon. I, I guess I still am. It's not something you ever stop being. It's just something you stop doing. And I would do it all again. I would do it sooner, but it took me a long time to figure it out.
Yeah, I'm often asked by, our learners, residents, and students how to navigate the toughest day in the operating room, the case that's gone bad. Um, when the residents feel really horrible at the end of the day. And what's your advice for the worst day in the OR and how you get yourself back the next day?
Um, well, the worst days are often not in the OR. They can happen in the OR, in the ICU. They can happen in a lot of places. And you have to be able to give yourself permission to heal. You have to be able to give yourself permission to forgive yourself. And I've found a lot of times families helped me do that more than I helped them. Um, and and then you just have to focus on the successes, and you've got a patient who did badly, or worst case scenario, even died in the OR. And you need to walk down the hall in the ICU and see the ones that are getting better. and go to your clinic and see the backside of the ones that are really happy and healthy and well going out the door and focus on those things. And, focus on things outside of medicine as well. It's really easy to get trapped into surgery being your whole life, and you just can't do that. It's too much to sustain. Took me a long time to learn that lesson, but when I did, I got much better about finding ways to relieve my stress and feel healthy and well about myself. But the big thing is you just have to learn to forgive yourself, just like you're gonna forgive anybody else who makes a mistake or has a bad day.
Would absolutely agree with that. And I think that that's something in our specialty that we don't talk about enough at our national meetings is how to, navigate work-life balance and give ourselves grace for errors and mistakes. You've been a huge advocate for work-life balance and wellness. In fact, my husband always asks me about you. How's that woman who always runs at national meetings? And you've really made a point of taking, personal time for yourself and strategy weekend retreats where you leave your cell phone at home and just take care of yourself. So I really admire that and I really stress that to our residents. So with your ski background, your love for the mountains, you've also done a lot of athletics. How have you really been able to maintain your fitness and love for all things outside cardiac surgery throughout your busy military and surgical career?
Um, yeah, I can't say I was always all that good at it. I mean, as a resident, I can remember running in Vacaville, California at 3 and 4 o'clock in the morning to before going in to make rounds and being on call and running around and around the hospital when I could. I always felt the need for exercise once I discovered that I liked it, which happened when I was in college, I guess. And but I didn't really get good at it, and to the point that I would set aside specific times that I could plan on having my time until I was maybe a decade into my career, and my residents um, were of a generation that just had a better attitude about those things. I started taking lessons from them, and then I decided that I had to plan to take vacations in advance and not permit my partners to say, "Oh, my kids have got this, and so can't you change your vacation?" Nope, got plans. That's what I'm gonna do. And I set aside. I always told the residents 5 a.m. to 7 a.m. is my time. If somebody's trying to die on you, you should call me. But otherwise, just cope. I'll be there later. And I just am entitled to a couple of hours out of every 24. And that worked out real well for me for a long time. And then I found that I'd go to national meetings, and usually the stuff going on real early in the morning wasn't really all that important. The breakfast they served was a lot of sugar. So I'd go out and run. And a lot of the men did too. I developed some interesting friendships with some of the men surgeons when I'd encounter them out on a run, and we'd run together for a while and be something other than a surgeon for a little bit. It's important to remember you are more than just a surgeon.
Yeah, I think that's really important. I love the idea of putting blocks on your calendar where the residents and fellows know that they have to call if there's an issue. And perhaps that's how we have so many 5Ks now at some of our regional meetings, is that you and others have led the way for that.
It's it's interesting. I've run very few of those 5Ks. I've registered for a lot of them, but it's funny how many times things come up, flights missed, and I don't get to the first thing in the meeting, or run into an old buddy and maybe have a few two carbon fragments the night before and end up walking that meeting, that run. It's it's a challenge at times. But yeah, that's true. There's certainly as much more emphasis at particularly our regional meetings more than our national meetings on getting out and doing more things.
Remember our first STS meeting that was virtual during COVID, and there was a Peloton challenge. And that led to many of our STS members posting their times and wattage. And it's really continued from meeting to meeting now, where you'll see these friendly fitness competitions getting more and more lively and competitive, which I think is great for our specialty. So, what's your favorite ski mountain?
Alta, Alta in Utah. I lived in Little Cottonwood Canyon for, 3 years. And I went to Alta every year for many, many years until about, 10 or 12 years ago. I found myself standing in line one day and I realized, I paid $105 to ski here today, and I'm spending more than half the time standing in line. I'm going to take up tennis, and next winter I'm going to tennis camp. And then I quit skiing.
Oh no, I was so excited to get you out to Utah, where maybe we could have a little regional meeting and get you, me, and Tom Varghese skiing. That would be awesome. We'll work
Well,
on it.
no, it's not beyond the realm of possibility that I could strap some boards on again. But of course, one of the things I love about Alta is they still don't allow snowboarders, do they?
No, absolutely not. That's why we don't go. My
Yeah.
husband's a snowboarder.
Some of my worst injuries skiing were associated with a snowboarder out of control running over me.
I wanted to turn to an issue that you and I know well from being women in cardiac surgery. We're facing a true shortage, as you know, of women in academic cardiac surgery. I think despite all of the challenges, we're still at about 3 to 5% women in academic cardiac surgery. And in a 2012 interview with Dr. Ross for the Women in Thoracic Surgery newsletter, The Oracle, you were very encouraged by our positive progress of women in medical school. Now, our medical schools do have more than 50% women matriculating. Yet it's been 12 years and we're still having similar numbers. So, what concerns me in mentoring women around the country is that many women are transitioning into private or rural community practice after a few years in academics, likely because of burnout and stress of the specialty. So, what do you think that we can do to retain more women in academic practice after training and be essentially better mentors and sponsors for our residents and students?
That's a very complex question and a real challenge. I mean, I have had uh, quite a number of residents that have come, women residents that have come through our programs and have declined opportunities to go into academic practice, and one who went into academic practice and left not long thereafter. I think the challenge is multifactorial. One, there are a lot more jobs available in private practice than in academic practice. So when a resident's coming out of training and they're looking at leftover student debt, and they're tempted by the salary ranges in private practice isn't really the right word anymore, employed practice, because
Right, right,
all of them are in some form of employed practice. And salaries in employed practice these days are so much higher than academic practices that that's a big force that drives our residents to that environment instead of to an academic practice. And then, the question of how to keep them in an academic practice once they get into it. Honestly, that's a function of how we treat each other as surgeons. Yeah, we're a very competitive group, and we can be very unkind in our competitiveness. And it just seems like a lot of times the men that I have worked with, and I wouldn't be surprised that you've had similar experiences, um, feel particularly aggressive toward women. They somehow feel a little bit threatened by this new group showing up. And so they they don't. they don't accommodate time off for the women as easily as they do for the men. A lot of times, particularly the early years in an academic practice, you're the one that's got to kind of suck up the worst of the calls. And to be perfectly honest, I think a lot of women have better sense and they just say, nope, gonna go somewhere else. And that's really sort of unfortunate. Another aspect of it is that, increasingly, as opposed to being cardiothoracic surgeons, which is what I started out thinking I wanted to do, you just can't do it all and do it well. And many of the women, probably have had three now, choose to take the thoracic track because they just find it intellectually more challenging. There's a lot to keep up with, less technically challenging, and less demanding of their off time. You don't have to come dashing into the hospital at 2 in the morning for a crisis in lung cancer nearly as often as you do for a crisis in aortic or coronary surgery. And that's a big determinant of the issue. I think it's important that, women like yourself and Jennifer Lawton and, name a few others who are still practicing strictly cardiac and environment in clinical environments, demonstrate by action that you can have a life outside the hospital. You can do these things. I mean, Dawn Huey just had a baby last year, and is holding down, I'd say, closer to half of the cardiac work at UT right now than a third, because we had, unfortunately, a death and have not really gotten back up to full speed on that yet. Cindy Harrington had two kids, and she's a congenital surgeon and she's really busy. And so, trying to kind of gather in some of the younger women and show them, I can do this, you can do this. It's really satisfying. But, the first issue is, as I said a while ago, practicing cardiac surgery is a really rewarding career, but it will consume you if you let it. And, if a lot of young women just don't want to let it. A lot of young men don't either, but there's more men uh, in the total mix, and hence that's why it's just such a small group of women. And I'm as happy to have them practicing thoracic. I'm ecstatic that, when I came along, the mentors that I had to look to were mostly men. Leslie Coleman and Carolyn Reed, but they weren't near me. They were out on the East Coast. Um, and now, since 2000, we've added more than 300 women who've been boarded. And right now, somewhere between 22 and 26% of trainees are women. So it's growing, and I try to look to the positive aspect of that. And as much as I would like to see more of them be cardiac surgeons because I loved it, mostly I want them to be successful and happy surgeons.
Yeah, I would agree with all that. I think that we've made great progress in our training programs. A lot of program directors are women now. And I would also add to any listeners that we have great scholarships through STS and WTS where we really encourage women and everyone to go into cardiac surgery and assign mentors, which has really helped. I wanted to ask you just a little bit about the OR culture. I've certainly had my challenges and opportunities in my career in various different cultures. And I do think it's a little bit different for women in the operating room, particularly when you're young and just starting out. So I hear about this a lot, and how give me some tips that you do to get through cases with a difficult scrub tech, or give us some advice. So do you have any specific advice that you could use that you could give our listeners about the OR culture and, how to navigate through cases or, deal with unfriendly assistants, to help our women listening?
You know, when I was in high school, I had a mentor, and probably the best mentors are people that you kind of connect with accidentally as opposed to some planned and intended thing. But anyway, she was an interesting woman. She volunteered to run our pony club group. She was a very wealthy woman in her own right and an attorney and things like that. And she just did this. And we became quite good friends. And she told me in a conversation about growing up to be a woman and try to maneuver in a world, she said, first of all, don't ever let there be a chip on your shoulder. Don't ever feel like you're owed something because you've been mistreated in the past. And that has resonated throughout the rest of my life. So, it's really important. You will encounter people that are aggressive in the OR, that are resentful, at all kinds of levels. When I first got to UT, there was a scrub tech who had scrubbed for one of the men in the group almost exclusively for years, and she just really resented me. She got angry that I would do endoscopic vein harvesting. Why can't you do things like Dr. So-and-so? Well, because I'm not that doctor, I'm somebody else. And over the years, we became really close. And now she says to that doctor, why can't you be like Dr. Carpenter? Um, but you just have to recognize that when people behave badly in the OR, as a surgeon, you're in charge. You set the tone no matter what anybody else thinks. You walk in there knowing that that's the case. And you can't let the tone be angry. You have to just say, this is your problem, not mine, and I'm going to move on and make this case work. And the same thing is true in all of your professional exposures. You have to take the high road. They can go as low as they want. You have to take the high road. And if you can really settle that notion into your head, and it's not as easy as it sounds,
Mhm.
then you can find that you can feel good about yourself because what they're trying to do is make you feel bad about yourself, and you can't let them do that. And recognize that, they have a problem and they're not happy because they have a problem. And me, I choose to be happy. I'd rather be happy than important.
I love that advice. I will think about that during our next operative challenge, and I think people will really appreciate that. I think I wanted to ask you a couple more questions, but since we're running a little short on time, I'm going to ask you one more question. So I think what I really, really love about you is just your frank advice. But you've really created a positive voice in our specialty. And in addition to that, you've had some really huge titles for a woman in your time. You were an early president of Women in Thoracic Surgery, president of the Southern Thoracic Surgical, which is a huge honor. And now you have a named scholarship after yourself, which I hope all women apply to attend the Southern. So, if you were just beginning your career, Dr. Carpenter, is there anything you would have done differently, either about your practice type or your career, or just being a woman in cardiac surgery?
Um, I've tried to live my life so that I don't have regrets. In fact, I went to medical school because I came to the point, I didn't get in the first time I applied. And I thought, well, I'm not supposed to do that. Um, but I realized if I didn't try again, I would always regret that I hadn't. And so I did, and that all worked out. If I could be 30 again, knowing what I know today, I'd start my career earlier. That's the only thing I would make different because it's been a great career. And, um, I was a lot older when I started. But what we are today is a compilation of everything we've been before. And so you can't really think about regrets and going back and wishing you could change this or that or the other thing. Because if you hadn't had that experience, you wouldn't be who you are today. And I'm pretty happy with who I am today. And I have been throughout my career. I mean, I've had difficult moments. I've had periods of burnout. I've gotten annoyed with people I worked with and, thought about quitting and then always just kind of looked around and said, nope, not going to quit. And you have to decide that you are who you are and to be who you want to be.
Where do you see our specialty going in 10 to 15 years? It's changed dramatically, as
Oh,
you mentioned,
yeah.
the past 10. Where are we headed in
You know,
cardiac
I,
surgery?
I think, and maybe I'm totally off base, but I think that the evolution of technology in our profession has been a very good thing. I actually would love to be 30 again and starting over because there's so much cool stuff going on. I see the whole practice of healthcare eventually changing from the silos of medicine, surgery, diagnostics that we exist today to being systems. And, people won't train to be cardiothoracic surgeons. They'll train to be cardiac specialists. And then within that group, some will do diagnostics and some will do medical type things and some will do procedural type things. And the collaboration between cardiac surgeons and cardiology over um, transcatheter valve work has really, I think, been a start to that. And that was not a choice we made. The FDA said, you're going to work together. And I think it has made us better and stronger. And I think that over time, gradually, that's the way we're gonna go. Medical school curricula have changed enormously. They're already emphasizing systems-based education as opposed to um, the the tradition where you just learn, this class and this class and this class and mix it all together. And I think our training programs are starting to shuffle off that way. And eventually that's the way our practice is going to be. Because it's just too complex to do everything. And you got to pick something that really suits you and do it really well. And that's the way that medicine's gonna proceed till eventually get to the hollow and the little magical thing that gives you a new organ like on Star Trek. But
With the artificial intelligence of it, right?
yeah,
Dr. Carpenter, it's been a true privilege to interview you for the Same Surgeon, Different Light podcast. I wanted to thank the Society of Thoracic Surgery for hosting this podcast series. And one last question, in all your positivity and on your way to Cabo San Lucas for a scuba trip, what will you miss about cardiac surgery in retirement?
um, I'm a little surprised that I haven't missed operating even a single day. And I only sort of miss working with the residents because I still do. And I will probably always, to some measure, remain engaged with this profession. Um, and go intermittently to professional meetings because I have a lot of friends I want to see. And I want to maintain that intellectual challenge of keeping up with how things are changing and what's going on. Um, but when the time came to stop operating, about 3 months before, I started feeling it's time. And I made the decision and I stopped operating. Um, and I think that it's really important that you have, and especially as you go through the more senior years of your career, define other activities. And when you feel like I'd rather be doing that, then it's time to go and do it. And then you won't really miss that much.
So speaking for all women in cardiac surgery and men, we really hope you keep coming to professional meetings. And I look forward to seeing you on the ski hill as well. So thanks
Well,
for your candor and for being such an awesome inspiration.
thanks. I'm not sure I deserve such high praise, but it's been a really good trip.
This has been Same Surgeon, Different Light, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT Surgery. And for more information about the Society of Thoracic Surgeons, you can go online at sts.org.